We are live. Howdy, everybody. Aaron Boster here, and thank you for learning about MS with me. It is Saturday morning, just after 8 a.m. Here in sunny Columbus, Ohio, and I was excited to jump online, interact with this global, growing online community, and answer your questions about MS. Chuck O is in the house. Chuck, how are you? It's great to see you. Chuck has been a longtime viewer on this channel. I'm going to promote him to moderator for this discussion. Pink Meadows is on the line. That's really awesome. I'm going to give a few minutes for some people to jump on. As you jump on, tell me where you're calling in from. So Edwards is in Baltimore. Chip is coming in from Boston. I just realized that I haven't plugged in my computer. I better do that before it dies. So you'll hear me talking while I'm scurrying about trying to get my computer plugged in and charged. Shame on me. I probably should have done that before we started. So I've got MBDB online. I've got Angela online. Guys, as you come on, tell me where you're coming in from. Chuck O is in Indiana. Chuck, I didn't know that you were in Indiana. That's awesome. That's just a neighboring state. Todd is from Indiana saying hello, howdy, hi. Hello, Todd. Aaron Reed is on from North Carolina. I've got D Hook in the house. This is fantastic. Vancouver is represented. Scotland is represented. I've got my computer charger here before this thing dies. Shame on me for not being more prepared. Let's give a few minutes for some people to jump on. There's 55 of us. Now, guys, before we get started with this live, ask me anything MS interaction. I'm going to ask you to fill the chat with flames. So go ahead and throw some flames in the chat. Let's get the whole chat filled with flames. And that's when I know that we'll be ready to start. Don't run away. I'm just trying to get my computer plugged in so that it doesn't die. I should have done that beforehand, but now we're good to go. I've got power. All right. So you see what D Hook is doing with those flames? Let's see if we can fill. Yeah, Angela's got it going on. MDB's got it going on. Go ahead and fill the whole chat with flames. We've almost got it all the way filled up. That's going to be my signal that you are ready to rock and roll. Elizabeth is in the house. David's in the house. Dre is in the house. James is here. Good morning, Ohio. Joe Sider says he's got a little flame going. We did it, guys. We filled the whole thing with flames. Thank you very, very much. That's awesome. There's 69 of us online right now. I've got 14 thumbs up, and we haven't done the first question. This is an exciting Saturday morning. Let's go ahead and fire up some questions. So Sonia writes, hi, Doc. What is the treatment for orgasm disorder in MS? That's a question I love. Sex is super awesome. Sex is very important, and MS can interfere with sexual function. So what do you do for difficulties with orgasm, challenging orgasms, or inorgasmia? That's a terrible word, meaning you can't achieve orgasm. So there's a lot of things that we can do. There's primary sexual dysfunction, secondary sexual dysfunction, and tertiary sexual dysfunction. And these are different aspects of the circuitry of sex, which can be messed up in the setting of MS. Primary sexual dysfunction is when there's damage to the brain or spinal cord. So the sexual sensations from the down theres, which have to travel up the spinal cord to get to the brain, are interrupted or they're interfered with. And I'll teach you a pro tip that I am very fond of. I've made videos about this topic. It's a trick that I was taught a long time ago. It's the vibrator trick. So you need to purchase a plug-in-the-wall vibrator. All right, I'm being dead serious here. I'm not talking about a double D battery thing. I mean a plug-in-the-wall, high-powered vibrator. You need one of those bad boys. You plug that in the wall. You get some water-based lubricant because it increases skin sensitivity. And then you apply that plug-in-the-wall vibrator where it feels good, whether that be on the glans clitoris or the glans penis, whether that be on the shaft of the penis or under the testicles, whether that be on the vulva. The point is that you can provide overdrive stimulation. Now, why do you need to do that? Because when the down theres are stimulated in primary sexual dysfunction and the message is going up the spinal cord, damage to the spinal cord of the brain, the message dies, it doesn't get there. There's too much interference. It's a lot like what we're talking right now. I'm using an indoor voice. I'm not screaming, and you're just sitting there casually listening because there's no interference between my mouth, camera, microphone, and then your speakers and then your ear. But let's pretend that you were trying to listen to me and I had 100 people in this room. and everyone was talking and jabbering and it was loud in here, I would have to scream at the top of my lungs for you to be able to hear me. I would have to provide overdrive stimulation to overcome the interference. Same thing with sexual function, primary sexual dysfunction. We can use an overdrive stimulation, that plug in a vibrator with a water-based lubricant, and we can stimulate the down theres adequately so the message gets up to the brain and the brain says, oh, now I know what to do. So there's a lot more that you can do with sexual dysfunction, but I love that question about orgasm disorder. One other quick tip is Scream cream. That's right, it's a compounded cream. It's got theophylline and Viagra and some other ingredients in it. You rub it on the down theres and it engorges the tissue with blood and causes them to swell and become more sensitive. It's an awesome thing. It's called Scream cream. That was a great first question. Thank you very much for asking it. Aaron Reed follows it up with another down there's question, talking about why is it that I keep peeing so much? So I'm going to presume a couple things to answer this question. I'm going to presume that Aaron may have multiple sclerosis and that he's having some difficulties with overactive bladder, meaning I get up way too often to go. We call that urinary frequency. Nocturia, which is a doctor word for I get up lots of times to pee at night. And urgency, like I got to go right now. And if I don't go now, I'm going to go anyways. And oftentimes people can't make it to the bathroom or they can't get their pants unzipped in time and they may start to go before they want to. And so these are problems that we can see in the setting of MS when there's damage to the brain and spinal cord. It's actually very, very common. And there's lots that we can do to sort it out. One of the first things we want to do is we want to make sure that we understand the history and that there's a history of overactive bladder and not urinary retention. Urinary retention symptoms are very different. It's when you need to pee and you can't get it out, or you pee a little bit and then you have to immediately go back and pee a couple minutes later. Sometimes a gal may be sitting on the toilet to pee and she stands up and says, darn it, has to sit back down and continue to pee. Or you may have difficulty emptying your bladder and you're pushing on your bladder, kind of bending over with your fist in your belly, trying to get yourself to push all the urine out. You can have a really hard time peeing and your bladder can be full of urine. And after a certain point, it can get so full, push, you lose all your urine. And that's typically an experience where the person's not aware it's going to happen. With overactive bladder, you know you need to go and you're sprinting. With urinary retention, you might not be aware. Both problems can happen in MS. And the way that you sort out one from the other is by taking a careful history and listening. And there's a tool that we use at the clinic called a bladder ultrasound machine. Now, I made videos on bladder on this channel, and I've done a video where I explained exactly how we use the bladder ultrasound. It's on the surface of your belly, on the outside of your body. It's not invasive. And what we do is we have you empty your bladder into the toilet, and then we measure how much urine is left in your bladder. And if it's over 150 cc's, then you're actually retaining. If there's not 150 cc's, that helps support the idea that it's overactive bladder. Now, what do you do about it? Well, there's a lot of things that you can do about it. One thing you can do is you can time your voids. So you can decide at the top of every hour, I will go pee. And whether I need to or not, I'm going to constantly once an hour go and try to empty my bladder. Because if you're constantly emptying your bladder, you're never going to have an oh no moment. There's also lots and lots of other things we can do. Increasing your water intake, not decreasing, but going up on your water intake actually helps overactive bladder. Because if you're not drinking a lot of urine, your urine is super concentrated and it's really, really irritating to the surface of the bladder. And that causes the bladder to spasm and creates problems. So increasing water intake helps. Going to the bathroom where you schedule helps. There's also a host of medicines that we can take. Now, that was a good question. Charles Boster is on from Powell, Ohio. Dad, how you doing? It's great to see you. Thank you so much for always supporting me. You're awesome. There are 94 people that are online right now. If you are liking what we're doing, definitely throw a thumbs up in the chat. Let's get that thumbs up close to 100 if we can. Now, I took a long time on those first two questions because they were awesome, awesome questions. Let's jump back into the mix and see where the next question is. So the Jankel, and I'm sorry if I said your name wrong, is writing from Bosnia. That's really, really cool. I've never been to Bosnia. I've been to Serbia and Croatia, which are kind of nearby-ish, but I've never made it to Bosnia yet. He writes, I'm really lucky having great neurologists as my doctors. I count you as one of them. Oh, that's really awesome. Now, I think that's such a kind thing, and it means a lot to me because I'm probably not going to get to meet you. And the fact that I can help provide some education and information and help up your game means a lot to me. This channel is about education. It's about engagement. It's about empowerment. It's about energizing people. It's not medical advice that replaces what your doctor says. So I can't be your internet doctor. But what I can do is I can teach you tricks and tips, and I can give you education about MS so that you can live your best life despite having the condition. And hopefully I can help you prepare to inform yourself better about the disease so that you can have more engaging discussions with your clinician. That's my hope. And thank you so much for joining me today. It's really awesome. Jen McGraw is in the house. Good morning to you. So D Hook writes, I have PPMS. Do you think I'll be in a wheelchair in coming years? So D Hook, there's not enough information. It is not a guarantee that you're going to be in a wheelchair just because you have primary progressive MS. It does not mean that. And that's not been my experience taking care of people with PPMS for over a decade and a half. There is a risk of progression of disability, no question. And what would I do to fight against that? I would take Ocrevus. Ocrelizumab is the only FDA-approved medicine for primary progressive MS, and it's a highly effective medicine. And it slows down progression of disability in PPMS by about a quarter, by 24%. It slows progression of walking disability by 25%. It slows brain volume loss by 20%. So it does some really good things. It maintains hand function and cognition. And I definitely would want to apply that drug. I would also want to make sure that you are physically active and engaged continually with physical therapy type exercises, both in a PT suite and at the gym on your own. I would want you to have exercise as part of your lifestyle. That's going to slow brain volume loss. It's going to keep you in the best condition possible to give you the best chance of walking unassisted the longest that you can, hopefully forever. I would pay attention to my diet and not eat fried foods, fast foods, processed foods, foods with ingredients that you can't pronounce, sodas. And I would supplement my vitamin D. I would also want to make sure that I was getting some sun. I would want to make sure that I'm not smoking because smoking will speed up your MS. And I would want to make sure that I'm taking a moment each day for mindfulness, to center myself and be in the present moment, to help manage stress. So that's called being 5 for 5. And I want someone with PPMS, just like I want someone with RMS, to be 5 for 5, to give you the best chance of never, ever visiting a wheelchair. And if you're in a wheelchair, to give you the best chance of living the most full life possible, despite the fact that you're in a chair. So that was a great question. Let's go on to the next one. Julia writes in, I have the JC virus. Am I able to get the COVID shot? Yes. So having exposure to the JC virus is not uncommon. Half of humans have it. And being positive to the JC virus has no bearing on any vaccination on Earth. So JC virus positive or negative does not come into play when trying to figure out the risks and benefits of taking a COVID shot. So have at it. I would 100,000,000% recommend that you do that. The next question comes from Elna. And Elna writes, hi, Dr. Boster from Holland. Well, hello, Elna. Holland is a really, really cool place. And one of my kids is considering being an exchange student and considering where they may want to go. And Holland came up in a discussion. I've been on Rebif for 17 years, started this week with Techfidera. That's awesome. So Elna writes, what are your thoughts? So I think Rebif is a low efficacy medicine. It was one of the very first medicines to come out for MS. It's a beta interferon product, and it's not remarkably impressive. It decreases relapses by about 30% better than placebo. It has a very small impact on progression of disability, and it's got a lot of side effects. I don't think that it's a robust medication. And so if you're on Rebif and doing great, God bless you. I think that's great. But if I'm choosing a drug with you, I'm not going to reach for that low efficacy drug. Techfidera is a step up. Techfidera is a pill that you take twice a day. And based on the confirm and define trials, which we participated in, went back when I was an assistant professor at Ohio State. And what we found was this drug was a very solid drug. It was a better product from an efficacy standpoint and from a tolerability standpoint. So I think it's fantastic to go from Rebif to Techfidera. Thanks for sharing that with me. All right, so Angela says, Chuck, I cheat and type flame and it pops up. That's awesome. That's a good tip. So Dulce Mia writes in, good morning. Well, good morning. And she's writing in from Colorado. That's pretty awesome. How common is dysphonia after a relapse? A new lesion, so no new lesions and no new Ocrevus, but my dysphonia seems here to stay. Speech therapy is helping. So phonia is making sound, and dys means you don't do it so well. And unfortunately, MS can interfere with the circuitry of vocalization and making sounds. People can develop difficulty with projection, making their voice loud enough. They can have difficulty with enunciation and with speech and the mechanics of speech. And fortunately, speech pathologists are rock stars at helping you with that. And they quite literally retrain your ability to enunciate and make sounds, along with a lot of other really important things. Speech pathologists are awesome. So is it common? I don't think it's common, although I do see it plenty. And there are several different kinds of dysarthrias or difficulty with phonation that someone with MS may experience. And if you've been in the space long enough, I can hear different ones. So I can hear an upper motor neuron dysarthria. I can kind of hear a taxic dysarthria. And so that's not common, but I see it plenty. Now, David writes in, would you count erectile dysfunction and bladder problems as a relapse if I'm urinating every hour and have problems with ED? So that's a really good question. It's not uncommon for people impacted by MS to develop bladder dysfunction, as we talked about in the question a few minutes ago. And it's unfortunately not uncommon that gentlemen can develop erectile dysfunction. Whether it's an attack or not depends on how it presented. So if you had a relatively quick onset over the course of a couple hours of having normal bladder function and then suddenly having loss of control and loss of erectile function, that could be something that manifests in the context of an MS attack. That's not commonly how I see it, however. Oftentimes it's a slow burn where it slowly comes on over time, or it may be the residual after some MS attacks. But I wouldn't a priori say, if you have bladder and erectile dysfunction, that means it's an attack. Now, it's a symptom and that stinks and you'd want to get it treated. And there are plenty of things that we can do for bladder dysfunction in ED. Sharon's throwing up some flames. I'm loving that. So Emra is calling in from Switzerland. That's freaking awesome. Switzerland is an amazing, amazing place to visit. Mediocre Art Channel. That's kind of a fun name. The Mediocre Art Channel. Hello, doctor. Does MS cause eyelid twitching for like a week? It can. That's called blepharospasm. And people can have like a twitching of their eye and it can drive them bonkers. It's really, really frustrating. I helped a very dear patient of mine just yesterday address this. And we could use medicines that were invented to treat seizures to help with this. So you can use medicines like Keppra or oxcarbazepine, Trileptal, or Tegretol, and try to stabilize these cell membranes and get that to stop. Now, sometimes it can happen because of excessive caffeine overuse or because of insomnia and not sleeping very much, but it can happen in the setting of MS. It's very, very annoying, and we can treat it. Good question. RX writes in, hi, I'm newly diagnosed with MS. I'm going to start with Mavenclad for my first treatment. Is this too weak or should I talk to my doctor about an infusion? That's a good question. Now, obviously, RX, I don't have any information on you, so I don't know anything about your clinical history or your examination or your MRIs or your lab studies or your CSF. I don't have that info, so it's impossible for me to weigh in. I will say that starting with Mavenclad first line is awesome. Mavenclad is an effective medicine. I think it's the king of the pills, and it might be a very, very reasonable place to start off. There was a great trial done which demonstrated with class 1 evidence that Mavenclad works in clinically isolated syndrome, so the very first attack that will go on to become MS. And it's recommended to be used first line like that in Europe and in other great, awesome places in the world. Unfortunately, here in the United States of America, the American FDA saw fit to make it second line. And even though there's excellent evidence for its use first line, it's not approved first line. Now, fortunately, if a doctor feels passionately that it's important, they can petition and try to get it approved. All that stated, I think it's a great drug. I think it's a good drug to start with. If your disease was particularly aggressive, we might actually start with a monoclonal antibody. But again, I don't have enough information to decide. Now, we've been on for 19, almost 20 minutes. There's 126 of you online, which is really, really cool. My name's Dr Boster. I'm an MS neurologist in sunny Columbus, Ohio. the founder and president of the Boster Center for MS. I'll throw our website down in the chat in case you wanted to check us out. And I'm totally digging doing this live stream, Ask Me Anything MS. Now, there's 62 thumbs up. Let's try to push that up. Do me a favor, guys, and you may have to jump out of the chat, click the thumbs up button and jump back in. But let's see if we can push that thumbs up upwards to 100. It helps out the channel a lot. Lets me know that you love what we're doing. Next question is from Bonnie. And Bonnie writes, my question is about muscle spasms, Charlie horses. I've been taking magnesium and plenty of water. My neurologist doesn't think it's the MS. Well, I find that people impacted by MS very frequently have spasticity, spasms, cramps, Charlie horses, limbs that are hard to bend. I would say about 70% of people impacted by MS have that. So I'm not exactly sure why a neurologist caring for someone with MS who has spasticity wouldn't think that those were connected. And I definitely treat a lot of spasticity. What's the number one thing that you want to do to treat spasticity? Stretch, like for real. Like you want to stretch. And you want to hold each position for 30 seconds minimum, all right? So by holding for 30 seconds minimum, you're teaching the muscle and your brain what's supposed to be going on. And I would stretch out once when I wake up in the morning before I exit my bedroom. And then I would stretch out before I went to bed at night when I enter my bedroom and I'm not leaving the bedroom again until the morning. I'm there for the night. I'm going to get ready to go to sleep. But before I do, I would stretch out again. And then I would stretch once in the middle of the day. And if you stretch when you wake up once in the middle of the day and then once before bed, that's going to be really helpful in addition to the magnesium and the water. And then I would look at whether I need a medicine. There's a bunch of medicines that are really, really helpful. I'm going to cough. Hold on. Sorry about that, guys. And medicines like baclofen can be super life-changing. So when you have spasticity from MS, you're missing the neurotransmitter GABA. And GABA is the stop neurotransmitter. And so if you don't have enough GABA, then your muscle doesn't know to turn off. So like, let's say that you're trying to bring your arm in like this, right? For this big, massive bicep I got. And the tricep has to relax. So GABA, the neurotransmitter GABA, at the level of your spinal cord turns that off so that your arm can go like this. If GABA doesn't turn this off, your arm's also going to do this. Now you got a tug of war and you have spasms and cramps and a limb that's hard to bend. So baclofen is a pill of exogenous or synthetic GABA. So you swallow the GABA and it relaxes and allows you to move your arm properly. And so taking baclofen once before bed or taking baclofen 3 or 4 times a day, depending on the degree of spasticity, is very, very helpful. Now, I've got several videos on this channel. I've got an entire playlist on spasticity. And so definitely check those out with lots of tricks and tips on how to make life palatable with spasticity and MS. So I love Joe Bonnie's question. What about lady bits? So I'm not sure what you're talking about in specific. Maybe you were referencing David's question about sexual dysfunction. And so maybe, Bonnie, if you can clarify specifically what about lady bits we're talking about, I'll try to answer the question. Ann Walsh writes in, on Tysabri for 14 years, is there a managed way to come off of it without real bad breakthrough relapses? I'm a bit worried going forward. Thanks, Dr. Boster. So, Ann, there is absolutely a way to do that. And the point that you're bringing up here is if you're on Tysabri and you stop cold turkey, about 3 months later, all your white blood cells that have been out in the bloodstream are going to bum rush into the brain. And if they do it too quickly, it can actually cause what's called a rebound. And it's a really unpleasant thing. The official name is immune reconstitution inflammatory syndrome, or IRIS. Now, my late mentor, Dr. Omar Khan, liked to call it CIRIS, cerebral immune reconstitution inflammatory syndrome. So in honor of Omar, who's passed away now, let's call it CIRIS. 1 second while I blow my nose. 1 second, guys. Woo! I got coughing and sneezing and my nose is running. What's going on? So the way that you prevent all the cells from bum rushing back in is, at least what I do, is when I stop Tysabri, the next month when you would normally come in for Tysabri, I give you 1 gram of steroids. And then I do that for 3 consecutive months. So we stop the Tysabri, and then by giving you a pulse of steroids once a month, we slowly allow the cells to go back. They don't bum rush in. And that works very, very well. Another way to do it is to go on to another highly effective therapy. And let's use ocrelizumab as an example, because there's been a lot of transitions from Tysabri to Ocra in my practice. And so if you're on Tysabri, I want to give you the Ocra very close to the Tysabri, because that way we're going to deplete all of your B cells and there's less cells to bum rush in the brain. And when those T cells come into the brain, they don't have B cells to help co-stimulate them. And so that's another way of helping smooth this transition. The point is there has to be a strategy. What you don't want to do, recently I had this bad experience where a patient was referred to me from another provider who sent them for a second opinion about what to do after Tysabri. And I was talking to the patient wife, and I said, when did you last take Tysabri? About 2.5 months ago. And I said, well, what's the exit strategy? They said, well, we were referred to you, and we got in today, and it's been 2.5 months. They've been off Tysabri, and they're really at the cusp of bad things potentially happening. So what do? I actually gave them steroids in my office that day to quell inflammation for fear that they would have this iris if we waited any longer. So Ange O writes in from Sydney, Australia. That's awesome. Howdy, howdy. I would love to visit Australia sometime. It's definitely on my bucket list. Angela Marsh writes, do you recommend Tysabri infusions over the new injection form? I have been offered the new injection form, but sitting on the fence. So Angela, the manufacturer of Tysabri, Biogen, did this trial, and they didn't involve anyone that I know. I wasn't involved in the trial, and none of my colleagues that I'm familiar with were involved. And as a result, I don't know very much about the sub-Q formulation. I know that it needs to be given under observation. I know that the EU approved it. I know that the American FDA said absolutely not, no. And in talking with the manufacturer, at least the folks I was speaking to, there's no efforts being made to revisit that. So I don't have personal experience with it. Now, I have a lot of experience administering IV Tysabri, and I'll share with you that we do it fast. So we've been giving most people Tysabri infusions in a half an hour. So it's typically given an hour. We've been giving it in a half an hour with zero problems. And so it's a much, much faster experience. And so I really wonder whether sub-Q is better, whether it's necessary. I feel like I can get someone sitting in an infusion chair, spike their vein. A half an hour later, I've run the drug in. They may choose to leave of their own accord and not stay for the observation hour. And that's fast, 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 safe, 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 and it really works out very, very well. So I don't know enough about the sub-Q to really give you like deep insights, although I really feel very comfortable with the IV. At the end of the day, the idea is that you're going to get the Tysabri in your body. And I think taking Tysabri is a highly effective therapy. So either way you take it, I think that's really great. So Joe Bonnie, who was asking about lady bits, is writing in from London. That's awesome. Let's see. Claudia writes in, I'm in terrible pain. I've been up all night. Claudia, I'm so sorry to hear that. That's super stinky. I hope that you get some sleep, and I hope that your pain gets better. Miss D is in the house and writes, hi, doc, from Holland. Well, hello. Love your live streams. I have a question for you. Okay. Is it possible that a lesion along the right occipital horn causes dysfunction of the left hand fingers? No. So lesions on the occipital horn, she's referencing a specific portion of the brain in the back of the brain, in the area that controls vision. And if there's damage there, it would not impact your fingers. And so the brain is wired in a really, really weird way. So a lot of neurology school is memorizing all these different paths in the brain, and damage in the occipital horn area is not going to code for hand function. Hand and finger function is way forward in the brain. And I wish I had a map here that I could show you, or like a diagram. Now, we've been doing this for almost 30 minutes. There's 95 thumbs up. There's 147 of you that have got online, and that's awesome. Do me a favor and let's push that thumbs up a little bit. Let's try to get it up above 100. So 3 of you watching right now are digging what we're doing. There we go. Thank you, guys. I love that. Now let's jump into some more questions. Diane Gonzalez is on the line. And Diane writes, I just started Aubagio 14 milligrams 2 weeks ago. Congratulations. I have extreme fatigue, she says. Only have about 3 to 4 hours before I'm exhausted. Is this normal? Are there meds that will help? Will it get better? So some people on Aubagio can have fatigue. Of course, having MS, you can have fatigue. And that stinks that you have such a small window of time. I would need to have a better sense of, was it really linked to the Aubagio? Like you had awesome, boundless energy and you started Aubagio and now you're exhausted? Or were you exhausted already and now it's just a bit worse? Because that matters. We have to try to figure out if you are going to acclimate to it. And my opinion is that 2 weeks is nowhere near long enough. We may need to try to stay on it for a couple months before we can sort that out. Unless, of course, it's not tolerable. We can't wait that long because you're just so fatigued. But if we could, I would want to see what happens if we're on it a bit longer. Also, there's lots of medicines that we can give you to trick you into being more awake. And so I think there's a lot of different ways that we could slice and dice this. All right. Let's see what else is cooking. Julia writes in, I have JC virus. We've already answered that question. So Stephanie has a request that I say hi to Zozo. So hello, Zozo from Aaron. I've got someone writing in from Prague. Prague is an awesome, awesome city. I love visiting Prague. I have the best time there. It's a really, really cool history, a cool city with lots of different awesome influences from Eastern Europe and from Western Europe. And I love that place. And so howdy, it's really nice to see you. Rendezvous. Let's see, what do we got here? Rendezvous de Rock. Okay. Hi. From Serena from Bermuda. Well, hello. I love your show. Thank you. I have spinal arthritis. And now previous MRI 1 year ago shows cervical stenosis. Would you recommend a doctor to do another MRI of the brain and cord? So not a lot of information, but what you're describing are extrinsic bone issues that are pushing on your spinal cord. And so you definitely would want to have imaging of that. And you may need to have a neurosurgery to open that up so that it's not being squeezed. Oliver Twist writes in, I'm on Gilenya, says Oliver Twist. Oh, I just lost, there is this question. More than 2 years, I'm 52 years old. Gilenya still recommended, or should I change my med? So Oliver, if you were in clinic with me, I would say the following to you. I would say in groups of people, there are medicines that are better than Gilenya. You're not a groups of people. You're one human. And if you have been crushing it on Gilenya, if you have an awesome quality of life, you're not inhibited by your MS, not failing the litmus test of life, you're not having relapses, you're not having new spots on future MRI, you're not having changes on your exam, your brain volume rates are normal, and you tolerate Gilenya, your liver enzymes are okay, I would stay on Gilenya. What I would take away from the discussion, however, is if there was any issues at all, we will escalate very quickly because in 2021, we have lots of other options. But I wouldn't just come off just to come off. Now, another consideration is your age. And 52 years old, my friend, is not old, right? Not at all, because I'm close to 52. And that's not old. But I start to get increasingly worried about continuing Gilenya as an individual ages. And definitely by 60, I'm going to feel uncomfortable with you on the therapy. I don't think it's wrong to be on it in your 50s. I just start to get worried as folks start to age. And so I think there's a lot of things at play. We have to think about your MS and how you're responding to the therapy, how you're tolerating the therapy, how safe it is for you. And then we have to take into consideration age factors as well. Hope that helps. Mr. Feeling writes in, hello. I'm 40 years old and I have had MS since age 28. I'm super stable with Avonex. And he says NETA, so no evidence of disease activity. SPMS terrifies me. In your opinion, should I consider switching to a more effective drug? The answer is yes, and I'll tell you why. Avonex is not good at slowing progression of disability, like at all. It's a really, really weak medicine as it relates to slowing progression. So other drugs, you've listed Mavenclad and Tysabri, I would include Ocrevus, I would include Lemtrada. Those drugs are much, much better at slowing progression of disability. And so you comment that you're scared about SPMS, about progression, and I respect that. And I would want a drug that does a better job. I would not want to stay on Avonex if that was my concern. All right. Let's see what else is cooking here. I've got a question from Caitlin who writes in, can you have MS your whole life, but it doesn't fully kick in until you're 19? I've had autoimmune symptoms my whole life. I've been sick my whole life, basically, always catching every bug that's around. So I don't think so. And I think that we can look back and we can say, oh, I've had lots of infections. I have an increased risk of infections, although that doesn't really correlate with then having MS later. Now, sometimes nature's too generous, and sometimes you can be sick most of your childhood and get MS when you're 19, and sometimes nature's too generous. What else do we have going on here? Dominic writes in, if one has RMS, then there is a chance they can move on to have SPMS. MS Geek writes in, hello, Dr. Boster. Have you watched the recent video by Dr. Beaber on drug prices? What is your opinion on the subject? So Brandon Beaber is a great guy. He's an MS neurologist, fellowship trained out in California, I think Southern California, and he works for Kaiser Permanente, and he does MS neurology out there. And I think he's a cool dude who has a great YouTube channel, not dissimilar to my channel. We both make videos educating people about MS. And Brandon and I have actually collaborated. We've done a couple of videos together. And I think he does great videos. So if you haven't seen Dr. Brandon Beaber, definitely go check him out. And you should follow him and you should like his stuff because he does good stuff. Now, he made a video where he was talking about drug prices being too expensive. And drug prices are too expensive. The drug prices in the United States for MS drugs are astronomically high. And there's lots of reasons for that. Some of them are very, very appropriate. Some of them arguably less so. I'm not going to weigh in on drug prices right now. I have seen his video. It's a very nice video. I don't agree with all of his points, but I agree with some of them. And it's an intense discussion. Thank you for bringing it up. And maybe I'll do a video where I respond to his video, or maybe he and I will do a collab where we discuss it. So XALDEJ, I don't know how to pronounce your name. Zelja, hello. What about depersonalization for an MS symptom? So you can have impact on personality and social interactions and a lot of stuff that's housed up in the frontal and prefrontal lobes with MS. And so you can have symptoms like that. It's not very common. Mary writes in, if you have breast cancer, would you stay on Ocrevus? So when we studied Ocrevus in 2014, 15-ish, did these clinical trials, Opera 1 and Opera 2 and Oratorio, we found that 6 women in the Ocre arms got breast cancer, which scared us. And we said, whoa, does Ocrevus increase risk for breast cancer? Well, there's now 200,000 people plus that have taken it. We have a lot of information, and we know the rates of breast cancer are the same as the general population. We do not believe that Ocrevus increases the risk of breast cancer. And I feel like the data is very, very solid about that. I've had patients that have survived breast cancer. They're breast cancer survivors. 2 women in specific that I think about a lot. Both have PPMS. Both are taking Ocrevus. And when the drug came out and we saw the potential warning about breast cancer association, we asked the oncologists who looked at it and said, we see no contraindication. Go ahead and give it to them. So I don't think that if you had breast cancer that you have to come off Ocrevus, because I do not think there's an association. Of course, you're going to have to talk to your doc about what's right for you. So in the sun by the beach, and then they specify they're in Miami. So go ahead and rub it in. Some of the best, awesome beaches and weather in the United States. So this person writes in, which drug do you prefer, Tysabri or Ocrevus? I think that that's kind of like saying, like, which sports car do you prefer, Ferrari or Lamborghini? So a Ferrari is a nice car and a Lamborghini is a nice car. And there's probably things that Lamborghini lovers love more about Lamborghinis than Ferraris. And there's probably things that Ferrari lovers think are better than Lamborghinis. But at the end of the day, if you got a Ferrari or if you got a Lamborghini, you got a really amazing freaking car. And I think the same thing is true about Tysabri and Ocrevus. I have lots of patients on both drugs, and there's different fits for different people. There's different dosing schedules. There's different things that each drug is kind of a little bit better at. But by and large, they're both amazing. And if you're picking between one of the two, you're doing an awesome job. That was a good question. Thank you. Monica writes in, I have developed a symptomatic palatal tremor due to a lesion on my pons. Is that common? And so, no, it's not common. And that's really, really annoying. And I'm sorry that's going on. And so, and the top of her mouth, her palate is kind of vibrating, and that's yucky. Womley Buckley writes, Queen Womley. Hi, Dr. Boster. I'm watching from the Channel Islands. That is so cool. And I'm a little embarrassed, but I have to look up exactly where that is. And so that's going to be my homework as soon as this live stream ends. So Leslie writes in, is there a particular age or length of time on Ocrevus that you could think of taking someone off Ocrevus if the person's doing well? So my canned answer is yes. I always stop medicines at death because the medicines don't work after death. But I wouldn't want to take you off an MS medicine before then. Now, is there a situation where you would come off a high efficacy drug? There is. And a situation might be you're stable as stable could be. And as you age, maybe now you're in your 70s, let's say. And so the risk profile, the risk benefit is changing. And we want to keep your MS treated, but we don't want that degree of intense immunosuppression. Then we might do a de-escalation maneuver and come off a highly effective drug onto something else that keeps the disease at bay, but in a de-escalation fashion. I have lots of videos on my channel where I talk about the concept of de-escalation. Although, if you're doing well on Ocrevus, maybe it's because Ocrevus is working for you and I might not want to change that. So Michael writes in, I'm on Gilenya and I'm having increased symptoms, mostly minor, but also some cognitive. I'm scared of changing from Gilenya because of the FDA warning. I've had MS symptoms since I was 30s, diagnosed in my 40s. And so Michael writes in about this concern of rebound, where rarely, and it's very rare, if you stop Gilenya, you then have a rebound because Gilenya takes 80% of your white blood cells and puts them in your lymph nodes, kind of traps them. So when you stop Gilenya, they come back out. And I think the key is that we're going to see rebound if you stop Gilenya and then do nothing. And so I would not recommend stopping Gilenya and doing nothing. I would consider stopping Gilenya, and then I would transition immediately onto something else so that there isn't an opportunity for those cells to bum rush in and create a rebound. And I have transitioned people off Gilenya hundreds of times, like literally. And fortunately, we've never had a case where there's been rebound like that. And I think as long as you're careful in the transition, it's okay. I would not be scared of coming off Gilenya as long as I was coming off onto something else. Now let's pretend for some reason you couldn't go on to something else. Then I would stop Gilenya, and once a month for 3 months, I would pulse you with steroids, exactly the same way I do when I'm coming off Tysabri to allow a slow return of the cells so they don't bum rush in. All right, so we've got 42 minutes in. Do me a favor, guys, and let's fill the chat with flames one more time. It's awesome to see. It helps the analytics, and it lets me know that you're having a great time. So go ahead and fill the entire chat with flame emojis. Let's flame it up. Do that for me, if you will. And I'm trying to see if I can use the trick that someone just mentioned where I write the word flame and it pops up, but I'm not seeing that. So guys, fill the chat with flames if you would. That's a woman's got it. A woman thriving with MS has got it. Angela's got it going on. Diane is doing it. Thank you, guys. Go ahead and fill that whole chat with flames. It kind of gets us all riled up and fired up. I'm digging it. Even so as well is doing it. Amy Welsh is doing it. This is fantastic. Thank you, guys. All right, now let's jump back into some questions. Let's keep going with these MS questions. So Sarah writes, and I've been awake since your live stream started. Just finished my first quart of water. Good job. That's fantastic. Now, I have to be honest with you. I haven't started my water game yet. I'm still deep into coffee. My dad is lighting it up with flames. Thanks, Dad. I've got Terry G who's in the house. This is fantastic, guys. Yay. That's so awesome. Thank you. That's a lot of fun. I love this global online community. It is such an awesome thing to be able to interact with you guys. And thank you for the flames. So next question coming in from In the Sun, the beach. This is the person from Miami. By the way, it is not so great in Miami. Too hot and humid to go outside from May to October, especially if you have MS. The traffic is horrible, very expensive. Okay, that's fair. Now I have to tell you, when I go down to Miami, it's normally to do some work. I get to leave Ohio and I get to see the water and the blue sky. Truth be told, a lot of times I'm inside going into hospitals or offices or conference centers. But for this Ohioan looking from afar, it looks awesome. And I appreciate your point. I normally am visiting Miami during vacation, so it probably has a very different feel for me. Thank you for bringing that up. All right, so Kathy writes in, how often does PPMS get diagnosed in error with presumably transverse myelitis? So transverse myelitis is when the spinal cord has inflammation and short circuits, and PPMS is a myelopathic disease. Myelopathic is a doctor word meaning predominantly involves the spinal cord. And so what you see with PPMS is a slow progressive myelopathic process. I'm using a lot of doctor words, I apologize, but where you have a spinal cord process and it's a slow burn, it's slowly getting worse over years. Transverse myelitis is typically an acute thing that happens suddenly. And so they are related, they both involve the spinal cord, but the timing is rather different. And so hopefully by taking a careful history that you can sort those things out. All right, let's see what else is going on here. We've got Waji Georges who writes in, why the first dose of fingolimod should be monitored in the hospital for 6 hours? Are there any issues with the heart later on? Very good question. So when you take Gilenya, Mayzent, Zeposia, ponesimod, any of these medicines, they're S1P receptors. They can bind to the heart and they will cause a bradycardia, so a low heart rate. And with Gilenya, we didn't know to study titrations. So the newer medicines that I listed all have titration packets where you take a certain concentration of pills for a couple of days, and that's how you ease into the medicine. Gilenya, we didn't think about that. It was the first one out. And so when you take it the first day, you can have a first dose effect where your heart rate goes down. Now, after the first day, you bind up all your heart receptors and then it doesn't happen again. And so as long as you stay on Gilenya, there's no problem. So there's no long-term heart problems if you're on Gilenya, unless you took the drug for, like, let's say over a month, and then you stopped it, and then you waited a couple weeks and restarted it. You would have that first dose effect again. Now, with the newer medicines, the way they circumvent that is by coming up with dose pack titrations. And so that way you don't have that first dose effect. And so I think that there's ways of making sure that you avoid heart problems downstream just by making sure that you keep taking your medicine. All right, so I've got text messages coming in, which I'm going to put aside for the time being. We've got a bunch of questions here. This is fantastic. Solana writes in, have had lesions on my spinal cord. After my last MRI, it showed they were gone, but I'm still having back spasms. Why? Because the MRI and the human are not matched up one-to-one. The MRI is taking a picture of structure, and the human is experiencing life and symptoms and function, and they don't always line up one-to-one. There can be other lesions in places that can cause back spasms. There can be other damage that you may not even see on the MRI right away that can cause back spasms. So it doesn't have to be a one-to-one. It generally is not. So Lori online writes, I think I just lost Lori's question. There it is. Can IVIG interrupt an exacerbation rather than steroids? Yes, it can. Seems steroid infusions over the years have caused the necessity for spine surgery and now crooked spine. Solumedrol can cause bone thinning. This is correct. And so, yes, there are other ways to treat an attack, and IVIG is one of them. That's absolutely on point. All right, so I had a reaction with Ocrevus. Can I take Kesimpta instead? That's a good question. Kesimpta and Ocrevus are both B-cell killers, but they're different. And I think it is possible that you would be able to tolerate one and not the other. I think that could happen. Given that there was a reaction to Ocrevus, I would want to understand the reaction, and that would help guide me about how I would recommend you start Kesimpta. I might observe the first couple doses of Kesimpta in the office. God forbid there was a problem. All right, so Jane said it took her a while to figure out how to do the flames. James, I don't know how to do it either, but thank you for figuring it out. Thanks for the flames. All right, can bands be in the serum and in spinal fluid? Asked Dana. Yes, you can. In fact, when you're looking for positive findings on CSF consistent with MS, what you're looking for is unpaired oligoclonal bands. So you see bands in the CSF that you do not see in the serum. So you have them over here and you don't have them here. They're unpaired. So if they're paired, that doesn't point towards MS. And so unpaired bands does. And that's why when you have CSF drawn at the same time, the same day rather, you need to have blood drawn so you can do that comparison. All right. Good morning, Dr. Boster. Any new progress with remyelination? Says T-Mom. No, I have no updates today on where we are with remyelination studies. They're ongoing. There are several that are ongoing. Our fingers are crossed. We're hopeful. We're very, very hopeful, but I have no updates today. When I do have updates, you better believe that I'll tell you all about them. All right, so I've got a question here from Mira Christian. I'm sorry, I probably said your name wrong. I apologize. Is it safe to supplement with B complex and CoQ10 enzyme colostrum besides vitamin D? I'm not an expert, but what I've read until now online, most have mixed opinions and advise against it. What's your opinion? So I think taking vitamin D if you have MS is a really good idea. I do not think that it's dangerous to take a B complex. I do not think that it's dangerous to take CoQ10 or colostrum. So unless there's specifics about you as an individual, I'm not sure why taking that would create a problem. Now, whether or not it's necessary is a separate point. And if you have a healthy diet, I don't know that you need to supplement those things. Taking a B complex is not an uncommon thing, although if you're eating animal products like eggs and meat and whatnot, you're going to get plenty of a lot of B vitamins. And if you're eating leafy greens, you can get B vitamins, or you can take a multivitamin. So I don't think it's bad. I don't think that there's a really strong contraindication not to do it. All right. So let's do another question and we're going to wrap up. Amy writes in, hi, Dr. Boster. One of the rare cases of going off Gilenya, had a massive relapse and still fighting it. And I'm so sorry. That stinks, Amy. I wish that wasn't the case for you. And I hope that you fully recover. Suzanne Baker writes in, good morning. I love your information, YouTube videos. Thank you very much. You know, it's become something that I really look forward to. Years ago, you may have heard the story. I had a no-show in clinic, and so I just got out my phone and I Ray Charles that I just talked into my phone. I think my very first video, it's a really cringy video. It was on the multiple sclerosis severity score and how you use that to prognosticate an MS. And I think that video is still up. God, I should delete it because it's nasty. It's just not a very good video. I didn't know what I was doing. Lighting is bad. Sound is horrible. Anyways, since that time, I started to make videos with more intention and more purpose. And now 6-7 years later, it's evolved into a weekly video on Mondays. And you know, a lot of times the videos are like 5 to 15 minutes long. What a lot of people don't realize is that it takes me hours and hours and hours, like 6, 7, 8 hours to make those videos. I'm not a videographer. I'm self-taught. And it's hard, and I love making them, but it's a labor of love. It takes me a lot of effort to put those together, and so I really appreciate when I hear that you appreciate them. It makes me feel good. So TVDB writes in, good morning. Any progress on BTK inhibitors? Yes. So I'm currently studying several BTK inhibitors at the Boster Center for MS. We're actively enrolling patients into 2 BTK inhibitor trials for relapsing MS and 1 trial for PPMS. I'm really excited. We've been doing a great job at our center identifying patients who are interested and helping them participate in the trial. BTK inhibitors, so butyrate tyrosine kinase inhibition is what that stands for. And BTK inhibitors are pills that you take twice a day, and they do 2 really cool things. Number 1, they block B cell communication without murdering B cells, and that's a cool trick. So there are some really effective medicines to treat MS, like Rituxan and Ocrevus and Kesimpta, that deplete B cells. Mavenclad and Lemtrada also deplete B cells. So that's a really effective way of treating MS. But when you deplete a B cell, when you murder a B cell, then there's potential side effects of murdering the B cell. So if you could instead make it so that you couldn't hear the B cell and prevent the transmission so the information isn't passed forward without murdering them, that would be awesome. And that's what BTK inhibitors do. Also, BTK inhibitors they impact microglia. Microglia are these cells that are resident in the brain, and they become overly active and they can cause a ruckus. They're part of the innate immune system, these microglia. And we've never, ever been able to get at them, to impact them. And this drug seems to be able to do that. So I am very, very excited about BTK inhibitors. We've enrolled 12 or 13 patients in total into the relapsing trials and 2 patients into the PPMS trial. And I'm very proud of that. I'm very, very excited to continue these trials. And I'm very excited to see how this drug, these BTK inhibitors play out. I think they're going to become the next best thing. I really do. I'm very excited about them. One of the really cool things about BTK inhibitors, particularly while we're studying them during a global viral pandemic, is that they don't seem to increase risk of infection. And I think that's awesome. We're going to wrap up, guys. We've been on for almost an hour. I've got to get my day started. I'm actually giving a lecture later today with Stuart Schlossman and MS Views and News. That's going to be in a couple hours, and that's definitely going to be online. And so you guys can check that out. Before we wrap up, how about one more round of fire? If you guys dug this live stream, if you would like more impromptu Ask Me Anything live streams, I want you to jump on there and fill up the chat with flames. Go ahead and flame up the whole chat and let me know that you're digging what we're doing. A quick update as we wrap up. Very soon, I'm going to be doing a scheduled monthly lecture on YouTube where I'll let you know ahead of time that it's coming. We'll make it aware on social media. I'll blast it on YouTube and on Twitter and on Facebook and probably on LinkedIn to let people know that I'll be doing it. It's going to be scheduled once a month so that you know when it's going to happen. And I'm going to ask everyone to jump on. We have a lot of things planned. We may be introducing some YouTube options to make it easier for people that want to participate and to ask questions to ask them, and for those that are disinterested not to do so. So a lot of things are cooking. I'm very, very excited about using this format for a scheduled educational session once a month. I want to thank all of you. Again, my name's Dr Boster. The founder and president of the Boster Center for MS. I'm an MS neurologist out of sunny Columbus, Ohio. Thank you for learning about MS with me. And until my next video on this YouTube channel, which comes out every Monday morning, or my next live stream, which soon I will be doing every single month, or even better yet, the next time I see you at the Boster Center for MS, this is Dr Boster saying, be safe, God bless, and take care. Until my next video, love you guys.